however you have your Zoom webinar set up. One is a chat. And if you open the chat, you will see that you have two options. You can send a chat to all panelists, that's us on your screen, or all panelists and attendees. So if you have a general comment you want to share in the webinar, I suggest you send it to all panelists and attendees. If it's something you want just us to see, you can send it just to the panelists. If you have a question, further across the bar on the bottom is something called Q&A, and it's got two little chat boxes. Please type your question there. All the panelists will see it. I will be reading them from that box and we'll be answering them live. When you type your question, only the panelists can see your question, but it's much easier for me to moderate than to dig through the comments section in the normal chat. So please put your questions there and we'll answer them in the question and answer session. Si jamais vous voudrez faire une question en français, moi je vais faire la traduction et les autres vont répondre en anglais, ou si jamais ça c'est un problème, je peux faire la traduction dans les deux sens. So everybody should feel welcome to express their questions in English or French, and I will deal with that in the moderation session. With that, I'm going to turn it over to Dr. Chris Aubry to open the session with an introduction of PRIME before we move on to our different panelists.
Great.
Go ahead, Chris.
Thanks very much, Gillian, and thanks to the PIHCI, as we affectionately call it, for inviting us to deliver this seminar to you today. I'm very pleasantly surprised at the number of people that are attending, and just to have the opportunity to speak to you today about the BETTER program, as you've just learned or just heard about. So as Gillian said, my name is Chris Aubry, and I'm the science lead for the Newfoundland component of the national PIHCI. PRIME, we call ourselves, the Primary Healthcare Research and Integration to Improve Health System Efficiency Network, which is a bit of a mouthful, but PRIME rolls off the tongue a little bit more easily. We have, of course, just the usual structure of the PIHCI here, with a tripartite leadership between policy, clinical, and myself as the science lead. I won't bore you with the details of that now. But I'll focus more on the panel today that I've managed to assemble. So I was asked to organize this, but there are people that are much more familiar with the BETTER program than myself, and they were fortunately able to take part in the presentation today. I am in addition to being science lead, as I told you, I'm also a family doctor and a researcher based at Memorial University, a professor in the discipline of family medicine here. I'm director of the Primary Healthcare Research Unit. I also, on the call, and who you'll be hearing presenting following me, are Donna Manka, who is also a family physician, professor at the University of Alberta. And she is one of the original founders of the BETTER program. So along with Ava Grunfeld, based at University of Toronto, who wasn't able to present today, the two of them were the main responsible for developing the BETTER program initially back, gosh, 10 or more years ago now, thereabouts at least. I'm sure she'll give you a better idea on the timeline when she speaks. I was very fortunate. I would say it's one of the better decisions I've made to agree to join the BETTER program when Donna and Ava asked me about 7 or 8 years ago. I got involved in the second phase, really the second major study of the BETTER program, where we ran an implementation study of the BETTER program in Newfoundland and Labrador here, or at least partially in Newfoundland. It was also run elsewhere as well, but we had several of the sites here. And as a result of that experience, both the results of the implementation study here that Donna will tell you a little bit more about, along with the results of the randomized trial that happened before my involvement that Donna and Ava ran, we convinced the Newfoundland government to allocate some resources and funding to the BETTER program. And over the last few years, they've been rolling BETTER out at numerous sites across the province. So Ashley is a primary care manager. Ashley Ryan is a primary care manager based with Eastern Health, one of the regional health authority based around St. John's, the capital city, of course, of Newfoundland. She's been instrumentally responsible for the rollout of Better at several sites across Eastern Health, and there are several sites in other regional health authorities around the province as well that we won't hear as much about, but are also in place. Ashley's going to speak about that, but actually before Ashley will be partly as a result of the success of the randomized trial and the implementation study, the Canadian Partnership Against Cancer was also convinced to allocate some funding and resources towards Better, to what we call the Better Institute, or what was called the Better Institute. And Carolina, I was about to say Carolina Aguilar, but Carolina Fernandez, I'm sorry, Carolina, is the executive director of the Better Institute and has been involved with the Better program really, I think, from its inception, certainly from before I started to become involved, and so knows the Better inside and out, and she'll tell us about the functions and purpose of the Better Institute. After Carolina, Ashley, who I introduced already, then we're very fortunate to have a patient partner who took part, who lives in St. Anthony, Newfoundland, the far northern tip of the island of Newfoundland. She has taken part as a patient in the Better program, and both her and her husband have. And she's going to give the patient perspective on the participation in the Better program. And then following that, if there's anything left to say, which seems unlikely, but if there's anything left to say, then I may have a few final words of some details that I wanted to contribute, just about my thoughts, mainly around my thoughts around what got us from research, because I think this will be of interest to this audience, what got us from research to a health system program implementation, because of course, as I think we all know, that's a big struggle in, especially in all types of research, but I think particularly in health services research these days. So
thank you, Chris.
Okay.
So I think, are we ready to turn it over to Donna?
Yes, that's please.
Okay, Donna, and I believe you have some slides you want to share with us. Yeah.
Okay, thank you so much, Chris. I'm just going to share some slides. And just about Better. Better stands for Building on Existing Tools to Improve Chronic Disease Prevention and Screening in Primary Care. So it isn't an acronym, but it is one of the better ones. So I'm going to talk a little bit about why Better came about, and that was over 10 years ago, as Chris alluded to. A bit about the classic, what we call the classic approach, the evidence behind the program, and you'll hear a bit more about more Better. So how it came about was we obtained funding initially through the Canadian Partnership Against Cancer. And we were concerned because we were seeing a tsunami of chronic disease, and we knew this was overwhelming our healthcare system. And a lot of you may be aware that 3 out of 5 Canadians have a chronic condition. And a third of our cancers are actually preventable through modifiable risk factors. And unfortunately, our patients aren't doing that or may not be aware of that. Family physicians just lack time and resources really to address chronic disease prevention. There's a plethora of guidelines. When we looked at the high level things that we should be doing in our practice every day, we found that it would add an additional 7.5 hours in our day as a family physician. So it's just not doable. So we needed a different approach. Well, we live in a disease care model. So the guidelines are all focused on different diseases, diabetes, heart disease, they're all different. There's a plethora of conflicting guidelines. As a family physician, when I see a patient come in, I don't see Mr. Heart Disease, I actually see this. This is our reality. This is an excellent diagram. We call it the spaghetti diagram. It really illustrates how there are root causes to chronic diseases. And a lot of those root causes are really how we live, our behavioral lifestyle, exercise, diet, all of these contribute to multiple chronic conditions. And guidelines, therefore, focused on just one of these does not really address Mrs. Smith that comes in and has actually 3 or 4 of these. You know, so we needed a better approach, hence Better. So I'm going to talk a little bit about the approach and what it is, you know, and what we found worked. So the classic better approach, we're focused on primary prevention, screening of cancer, diabetes, hypertension, and associated lifestyle factors, only high-level evidenced ones. We targeted patients 40 to 65 years of age, as this is the age group to which most of these apply. And we identified a role, an enhanced role in primary care settings. And we call that role the prevention practitioner. The prevention practitioner is informed by a toolkit. He or she also does an environmental scan to identify resources that can be made available to the patient. This is a member of the practice, not a new person, but usually it could be an RN, could be an LPN, a nutritionalist, somebody in the practice who obtains specialized skills in chronic disease prevention and screening. So it isn't a new individual, it's somebody that may have a little extra time that can complete some training, and it's a 2-day training session, and then dedicate time to have prevention visits with patients. The toolkit is really important to discuss. This toolkit was developed with the Center for Effective Practice assisting us in identifying high-level evidence and a clinical working group. And we developed a number of tools for our Better project. And one of the tools is a Better survey. Now, this survey is quite unique in that it has tools in it to assess and quantify how well patients are eating, exercising. It's informed by behavioral medicine, whether they're ready to change certain lifestyles or not. It looks at their chronic conditions. It also looks at family history so that we can tailor what screens and prevention actions are ideal to that unique patient. This really messy looking algorithm is what the prevention practitioner gets skilled in. It is a care map, and it shows the prevention practitioner what to do when certain conditions are met. So this is 2-day training where prevention practitioners learn what to do if a patient has certain conditions, what to screen for, when to refer patients back to the family physician, and they work with the family physician or primary care provider as to how independent they can do certain things. So they may be ordering mammograms or blood tests, all according to the care map. The prevention practitioner also provides the patient with a prevention prescription. And this prescription educates the patients about how they are doing with their health. Now that may include the screens, you know, whether they've been screened for high blood pressure, how their cholesterol is, whether they're due for a mammogram or a PAP. It'll also include lifestyle factors as to how well they're doing with exercise and diet. When the prevention practitioner meets with the patient, the prevention practitioner uses what we fondly refer to as a bubble diagram. And this diagram, the prevention practitioner will fill in details about how that patient is doing in terms of diabetes, heart disease, where they may be at risk. And that diagram is used to agenda set with the patient to identify, you know, where would they like to go in terms of improving their health. And then they move on to identifying goals that the patient can choose to improve their health or not. So the process involves a prevention practitioner being trained in prevention and screening. Patients are invited for an intervention. The patient fills out the health survey. The prevention practitioner reviews that survey, identifies what actions are unique to that patient that need to be addressed or not. It also includes, you know, where patients are informed why they do not need certain screens. Then they hold a prevention visit, educate the patient, and the patient is linked to resources. So this is all developed from original research, and this is the BETTER trial. And the original objective of the BETTER trial was really to improve chronic disease prevention and screening in patients aged 40 to 65. We were particularly interested whether practice level facilitation or individual prevention practitioner level intervention was effective. And this involved a two-way factorial cluster randomized controlled clinical trial. The primary care physicians were in Alberta and Ontario. There were 4 practices in each province involved. And in those practices, 4 physicians participated. The outcomes were at the individual patient level. So the patients were the unit of analysis. When we looked at outcomes, we developed a composite index. Now, what we did is we identified 28 prevention and screening actions that patients are eligible to receive. And we looked at baseline at what they had, and then at 6 months, what they achieved. And we had 4 groups that we looked at. We had a waitlist control group that received none of these. We had the practice level facilitation, where we had a practice facilitator come into the practices and optimize how the practices could address prevention and screening through goal setting or identifying patients at risk. We had the patient level facilitation, which involved the prevention practitioner meeting with patients. And then we had both. And what we found surprised us, because we thought the practice level was going to make a big difference. In the control group, 23% achieved their chronic disease and screening actions. When we looked at practice facilitation alone, 29% achieved. So there was a slight improvement, but it was not significant and it was not cost effective. When we looked at the prevention practitioner, the individual patient intervention, there was 56% achievement of actions. And when, of course, we looked at both, there was a slight increase in that. But really the difference was with the patient level facilitation. And this is where the classic BETTER came from. So when we looked further at patients' perspectives, we did a qualitative study and looked at what patients thought about this, and it was overwhelmingly positive. So this was the basis of the BETTER program. And from here, we were curious whether it would work in less advantaged practices, because the practices that we had involved were in Ontario and in Alberta were multidisciplinary team practices. So we did look at this in more rural, remote settings and found similar trends. There is more to BETTER. The BETTER Institute has received some support from, again, the Canadian Partnership Against Cancer to spread across Canada and deepen impact. But what we're applying in practice is only what we have good evidence for. So we have a number of trials underway to build on the BETTER approach. So one trial is called BETTER-WISE, and BETTER-WISE looks at looking at whether cancer surveillance can be improved with this approach. And I'll talk a little bit more about that because right now we are collecting some data on the 12-month visit for that. BETTER Health is looking at how effective BETTER is in public health settings. So we are looking at public health nurses delivering this approach to low-income neighborhoods, and is this effective? BETTER Women will be exploring community-based lay health educators in this kind of an approach. And Better Life is looking at the effectiveness of this approach in younger populations. So the Better Wise project, we identified 3 common cancers that we as family physicians often manage, you know, in cancer survivorship. And that is breast cancer, colorectal cancer, and prostate cancer. And we've blended the guidelines, and the prevention practitioner is being educated on meeting with patients and again, applying both better screening as well as cancer surveillance. And we're looking at how effective this will be. The Better Wise project also is considering a poverty tool. There has been a tool screening for poverty. We are using that tool in the project, and we hope to have some understanding of that tool. And that's a very brief overview. And at this point, I think we can turn over, you know, to our next presenter.
Thank you, Donna. So next we have Carolina. So Donna, you need to stop sharing and Carolina can bring up her slides. And you're still on mute, Carolina.
Thank you very much for that, Jillian. Hello, everyone. So I will be following up Donna's presentation on information that I'm sharing with you in terms of the Better Institute. As Donna and Chris mentioned, the Better Institute is the implementation arm of the Better program. And just to show you what I'm going to be chatting about today, we're going to talk a bit about the overview and the mission and vision for the Institute, what the core concept behind the Institute is, and I'm going to highlight some of the activities that we have engaged in since we were funded by the Canadian Partnership Against Cancer. So as Chris and Donna mentioned, we have been funded by the Canadian Partnership Against Cancer. And our main mission with the Institute truly is to advance the health of Canadians by contributing to a sustainable healthcare system, where our primary focus is primary prevention of chronic disease prevention and screening. And how we do that, as Donna specified, is we're really looking at the chronic diseases that have the biggest evidence for prevention, for primary prevention, which for Better are cardiovascular disease, diabetes, colorectal, breast, and cervical cancer, and their associated lifestyle factors, with a focus on patients 40 to 65, as this is the age group to which most screening recommendations apply. However, some of the recommendations, in particular, the lifestyle recommendations, can be adapted to younger populations and actually have been by some primary care settings and Indigenous communities whom we work with the Institute. So the Better Institute is very much built on the evidence behind Better. And as we learn more from some of the studies that Donna shared with you, Better Wise, Better Health, Better Life, as we learn more from those, any learnings from those studies will also be incorporated into the Better Institute. The principal areas of focus are training of health professionals. So this is who we call prevention practitioners, or as you can see, they're PPs. They are trained either in person in group sessions or virtually by us, with a maximum of 8 trainees participating in our sessions. These are led by our master trainers, so they work with the Institute. And once health professionals have received the training, they are invited to participate in a community of practice. So I will show you a little bit later in my presentation what that looks like. Along with that, we also have a train the trainer model. So this is previously trained prevention practitioners who are actively practicing in their settings within this role and who have experience implementing this approach in their own settings. We also have, of course, many managers who participate in our training so that they have a much better idea of what the role of a prevention practitioner is. And they are also eligible to participate in Train the Trainer if they are actively supervising a prevention practitioner. And Train the Trainer will be available coming in January of next year. The second area of focus for us is providing tailored implementation support to primary care settings in Indigenous communities. So we have 2 implementation leads that currently work with primary care practices and organizations. And we also have an Indigenous engagement lead who works with Indigenous communities or with practices or settings who serve large Indigenous populations to help adapt or adopt the approach to their particular communities. And in order to help all of this work, we also leverage IT capacity. For us, this includes a better web-based application, which I will tell you more about as well. And also for those of you who know the Ocean platform by Cognizant MD, we also have our better surveys that are available there. This is a platform that is well used, I believe, in Ontario and perhaps in other provinces, and is very much connected with some of the EMRs. So what are some of the highlights in terms of what we've accomplished since we started working with the Canadian Partnership Against Cancer? So since we started, this was back in 2018, we have provided 46 training sessions across 20 physical locations, and we've also provided 10 virtual sessions. And our participants have come from 6 provinces and 1 territory so far. And they represent 81 unique practice settings. 62 primary care practice settings have received implementation support from one of our implementation leads, with 84% of the practices receiving intensive implementation support to adopt the classic better approach as Donna described it in her presentation, while 16% are adapting the better tools to their setting. 19 First Nations, Inuit, and Métis communities have also been engaged and have received support from our Indigenous engagement lead to adapt or adopt the better program to meet the needs of their communities. And we are currently working very closely with the health authorities in New Brunswick and Nova Scotia to launch the program, including in some French-speaking communities. So what are some of our training highlights in terms of prevention practitioners? So to date, we have trained over 290 individuals as prevention practitioners. Over 60% of trainees come from a nursing profession. So these might be nurse practitioners, registered nurses, licensed practical nurses, registered practical nurses. Sometimes the designation changes between provinces. Around 56% of the trainees serve rural populations, which for us is really important for spread and scale. We also have 20% of trainees who serve disadvantaged populations, and 25% of trainees serve Indigenous populations. And 93% of our trainees rate training as very good or excellent, which is great for us to hear. So as I mentioned, once someone has participated and completed their training with us, they are invited to participate and become members of our community of practice. Our community of practice currently has 183 active members, and the platform really serves as a hub for PPs, so for prevention practitioners, to learn from each other's experiences, pose questions to our trainers in case they are experiencing some challenges in their settings as they incorporate their role into their workflow, as well as an opportunity to keep up their skills and contains over 40 resources, including better tools, resources, and test patient cases. To support implementation of the program, our implementation leads use several tools with organizations and settings to help them implement or adopt the program. These include a process map, which highlights the key decisions that are made during the implementation process to ensure successful program launch, as well as templates that can be adapted to any setting and are aimed at increasing awareness of the program for patients, physicians, and other team members. And all of these tools have also been adapted for Indigenous communities by our Indigenous engagement lead. Some of the key adaptations that we have made to serve the needs of Indigenous communities are adaptations that we have made to the health survey, which Donna shared with you briefly during her presentation. There are 2 modified versions, and these have been revised after consultations with Indigenous stakeholders to include more patient-friendly language and graphics, some visual representations of some of the information that we are looking for. The 2 versions are a patient version, which patients can complete on their own, or a prevention practitioner version, which is used by communities with a patient and is administered orally. The PP version, the prevention practitioner version, is accompanied by a health survey guide. And the health survey guide illustrates the conditions and tests for patients. And the prevention practitioner uses it along with the survey to explain the importance of why we're asking about a condition or a test and what it actually means. And it uses a lot of patient-friendly language. And we were very lucky to work with an Indigenous artist, Lisa Boyven, who was able to do the cover pages and the art for us. And these are just some examples of how we present the information to the patient, and our prevention practitioners share this. Another adaptation to our tool was the health and wellness prescription. So this is a modified, better prescription. It's a simplified design with patient-friendly language, and the colors have very much been modified to correspond with the health and wellness wheel. You'll notice that it looks very similar to the bubble diagram. It's just a different representation of those really core concepts that we cover as part of Better. In terms of IT, we really do focus on the Better web application. It allows primary care settings to electronically administer the health survey to patients and follow their progress in the program over time. The web app automatically generates the prevention prescription or the health and wellness prescription as appropriate based on the patient's answers to the survey. And the English version of the platform was launched in April this year, and the French version is expected to launch this fall. And as I mentioned before, to help implementation for those programs and practices that use already the Ocean by Cognizant MD platform, we have also built versions of the Better surveys into that platform, which automatically generate a progress note into that EMR for those practices. And that's the end of my presentation, so I will leave it there and have the next presenter present.
Thank you very much, Carolina. So our next presenter is Ashley. So Ashley, if you want to unmute yourself and go ahead. So for our attendees, Ashley won't be having slides. Go ahead.
Thanks so much, Jillian, for that. And I'm very happy to be here today. So thanks so much for having me, guys. My talk to you guys today is essentially to build on the concepts that Donna and Carolina just very nicely explained to the group. I'd just like to essentially tell you my story of how we implemented Better in Eastern Health and talk about some of our challenges and successes. So very excited to be able to do that. Just a little background. I'm a registered nurse. my background prior to working in primary care as a manager, I worked as a frontline RN in an emergency department, and I also worked in rehab and long-term care. So I really did have a lot of knowledge about chronic disease, and certainly saw a lot of chronic disease within my patients. So when I took the role in primary care back in 2018, I was introduced to the Better program actually on my very first day in the role. I met with Chris, and he gave me a great overview of the Better program. So then I was working towards getting a true understanding of the program and how we could implement within Eastern Health. Now, Chris had done a lot of research in Newfoundland, and had actually gained the attention of our partners at the Department of Health at the government level. And so we were actually funded some positions for prevention practitioners. So that was prior to me arriving. And once I took on the role, I was fortunate enough to get to travel to the Institute in Edmonton and receive the training myself by Carolina to become a prevention practitioner and to really gain that insight and understanding into how the program operated. So I was actually funded for 3 LPN positions, so licensed practical nurses, to become prevention practitioners. So once I had a true understanding of the program and how it worked, and we had the funding in place to hire people to actually deliver the service, I had to make the decision as to where we would implement the program. So the very first place that I decided to integrate Better was in a place called St. Mary's, which is a very small rural town. It's about an hour and a half away from our metro region of St. John's in Newfoundland. And my rationale for picking the site was for multiple reasons. The number one reason was because it had some of the highest rates of chronic disease right across Canada, particularly in diabetes. Also many lifestyle factors that we needed to work on within that region. And in addition to that, St. Mary's was notorious for having a huge turnover of family physicians, providers, and a lack of consistency for the region. My own upbringing, I grew up in a very small rural place in Newfoundland as well, actually in St. Mary's Bay, and being able to provide an essential service to small rural areas was something that I was very passionate about. So I was also very excited to be able to implement a program that would help patient populations because I really did have a true understanding of the lack of access to services within those areas. So since we implemented in St. Mary's, we've had a lot of great success. We've had, of course, our fair share of challenges too, and I'd like to just talk about some of those. Before I get into all the positives, I'll just briefly touch on some of our challenges about working in St. Mary's and rural areas, but ultimately why Better is so important to integrate into these places. First and foremost, it's a very rural population, and a lot of our areas within the entire province of Newfoundland are very far from acute care centers, metro regions. So, of course, all of that has challenges to accessing service. It's a very far drive for any form of diagnostics for the most part. So that's certainly been a challenge. The other challenge that we've experienced in St. Mary's is that most of our population is greater than 65, so the evidence-based group doesn't necessarily fit. At least these were the things that I was certainly warned against before implementing Better within St. Mary's. And of course, the thing I just talked about was the lack of consistent providers. So not having a true consistent family doctor, lack of continuity of care, not understanding the true patient holistic vision and picture. So those things were big challenges that I was sort of warned about implementing in a very small rural site. Well, we implemented in March of 2019 in St. Mary's. I hired a prevention practitioner just before that, and the Better Training Institute came and trained the LPN that I had hired for the role. And we set a goal to see 50 patients within the first 12 months in St. Mary's. And that number increased rapidly, very, very quickly. So to talk about our success, it certainly makes me a lot happier than to reflect on challenges, but of course that's how we learn and grow. You know, I had an amazing team of prevention practitioners who were trained and able to deliver the service. We had to become incredibly innovative in our approach. So, you know, we don't have a huge recreation scene in some of these very rural, small populations. We don't have a large number of group activities and those sorts of things to get the information out there about better. So we became very innovative in our approach. And I would certainly credit the Training Institute for our success, because they were very helpful in allowing us to adapt our process for what worked for us in St. Mary's. So we did everything from handing out surveys to patients if they just came for a regular clinic appointment and they were between the ages of 40 and 65, we did that. We also got creative in approaching patients in the waiting room by just simply having a chat, talking about better, you know, informing them of how they could improve their health. And the truth is, word travels fast in a small town, and before we knew it, we had grown to well over 100 patients within the first 6 months. So then we started to look at our outcomes, which were, we had a great amount of success from not only patient perspective, but also we had identified patients who were at risk for diabetes, at risk for cancer. So those things were, you know, we credit to our success and being able to work so closely with the Training Institute. So having them as our neighbors, I call them, even though they're all across the country, certainly credit them for our success, because anytime we wanted to do things a little differently or we wanted to bounce an idea, we were very, you know, lucky and fortunate to be able to contact them at the drop of a hat, and they were incredibly responsive, always have been, for our success and helping us adapt the program for what our needs were. Right down to, you know, if a patient, if we had multiple times where patients struggled with a certain question on the survey, we take it to the Institute, they work through it on their end of things and work to make that particular question better. So it, overall, our success in Newfoundland, in Eastern Health, particularly where I work, I certainly credit it to the Institute for their supportive nature. So once we rolled in St. Mary's and we were successful, we have implemented since in 3 other sites, and all of those sites are rural. We haven't integrated into the metro region just yet, but we are definitely growing, and it's very exciting. We have just most recently integrated better into a family practice clinic in a smaller place just outside of metro, and we're onboarding all of our patient intakes using the better tools. So very exciting work. I guess the other thing to talk about for our success in Eastern Health has been to be able to work so closely with Dr. Aubrey, who has not only a research lens and very understanding of the inner workings of better, but also brings an excellent physician perspective. So anytime I have integrated better into one of our rural sites, I've engaged Dr. Aubrey in those discussions, and he's been very instrumental to our success in facilitating those conversations from that physician researcher lens to talk about how it actually helps family practice. And it allows for family physicians to have more time to be able to focus on the important things with their patients and put chronic disease prevention at the forefront. So we've had a lot of great partners in Eastern Health, and you know, that I certainly credit to how well we have done. So Dr. Aubrey, I thank you very much for being such a great part of our implementation, and, you know, look forward to expanding through other regions throughout Eastern very soon. I guess the greatest part of our success, and it's probably a really good segue into our next presenter, is the patient empowerment aspect. And patients really enjoy the program. The feedback has been incredibly positive. I know Donna gave some great numbers about the patient feedback in her presentation, but I can certainly attest to that here for how well people have received the information and, you know, setting goals to improve their own health and that empowerment to take on new things, new challenges, to work with somebody, to be able to follow up with somebody about little changes that you can make to prevent yourself from getting a chronic disease. So the patient outcomes and empowerment have been the most exciting and rewarding part of doing this job for me. And like I said, I look very forward to being able to implement better throughout much greater regions throughout Eastern and across the province, and to continue to work with our partners to make it bigger and better, quote unquote better. So I think that's a good segue into our next presenter.
Thank you, Ashley. Yeah, there's been a few puns on better. It certainly lends itself to it. Couldn't hear me laughing at Donna's joke earlier. I was on mute. So Blenda is a patient partner with the project, and she would has some things to share with us. So Blenda, go ahead.
Okay, well, thank you, Ashley. It was actually quite a nice segue into what I have to say, and some of the things will just reiterate what you've already said. But and I don't have any slides, so I apologize for that. But as a patient partner here, I felt, I would be more inclined to just speak to my experience and with the Better program, what I liked about it, and what things I think could be done better, and also. And I guess from my experience in healthcare, this question was, do you think that Better is a valuable use of health systems resource, which I'll touch on as well. But as I'll start with my experience with Better, I worked in healthcare for 34 years, and I really hadn't heard much about Better until I became a patient after I retired, which was 2 years ago. And then one of my physicians suggested that I check out Better program and see if it was something that would be suitable for me to be a partner or a patient in. So I did, and I made an appointment, and I've had 2 visits actually. The first one began, I think it was October of 2019. And I went in, and our, I guess the PP was a LPN or a PC. She was trained in some type of nursing anyway. And I was very impressed that she explained the Better program to me. And we went through what I think Donna referred to as the bubble, in terms of looking at all the 3 different chronic diseases and my family history and my health lifestyle to see where my risks were. Now, I was, a type of person that did have some input and some I guess, previous experience with taking accountability for my own health and looking at lifestyle. You don't work in healthcare for 34 years and not be aware of chronic diseases and primary prevention and the client. And I refer to client because my background is actually social work, but I'll use client and patient interchangeably. So, I was well aware of some of the risk factors and my family history. With the chronic diseases. So our first visit, actually, I completed the survey. She explained the Better program. And then we did some of the reviewing the history, which came out on the survey, obviously. And, did some of the nursing things that you need to do for the program. And then, of course, I had a follow-up second interview session with her, and that's when we looked at my risk and what types of procedures I would need to do, and what lifestyle changes would be important for me to make in order to reduce my risk or prevent, the development of some of these diseases. So that was and we were scheduled to meet again in June, but of course COVID took away that opportunity to have that follow-up visit, which is unfortunate, because I've found since the time has elapsed, has kind of made me lose a little bit of the momentum that was on the go. But I found, in terms of what I liked about it, it was very informative. And I think, being the patient made me look at it from a very different lens. And I felt very reassured that I was going to have a good handle on what lifestyle changes I needed to make, as well as her telling me what procedures, tests that I needed to have at what intervals. So that was really, really helpful. And the focus on prevention, of course, which has been, something that we've always preached in health. But as a patient, I saw it from a different lens and realized how so important that it was. And the other thing that we did in my second visit was actually to set goals. And I mean, I have set goals in my lifetime for different things, but this felt very different. And I really liked that, the goals that we talked about were achievable. So as a patient, I felt, I wasn't reaching for the stars, but I certainly had some responsibility to, take control over my health, and felt empowered, as Ashley said, which was really good about that whole process. And I felt, that she was very knowledgeable. I was interested to hear about the training that happened at the Institute. I really, felt that she was very knowledgeable and went through all the different tools that we were going to be using as a patient and partner in Better. So that was really, really keen. And of course, the other pieces that I've found, the results, in terms of the follow-up with the procedures that I had to do. And we were fortunate that there was very little wait time back at that time for the procedures that I had to have done as a part of the Better program. It was excellent, actually. In terms of what could be done better, I'm thinking that we have dedicated, 1/2 a day a week to Better. That was prior to COVID now, and I felt that, that was probably not enough, because one of the things that I really liked about it was the time that it took. And I mean, really, it was a couple hours by the time we went through the process, the first visit. The second visit wasn't as long. And I liked that I wasn't rushed as a patient. And really, it was a whole new concept in terms of the different chronic diseases, and looking at it as a patient that, I had to kind of process, and so needed time and support from the practitioner. And, she took the time to do it. But as a result of her having, another caseload, because she does all the community clinics as well, which, is very time consuming, because in St. Anthony, we don't have a large population, but we have a huge geography. So, it takes a lot to do the community health piece for when they're visiting communities. So as a result of that, she only, is able to dedicate 1/2 day a week to Better. And so I felt that it was, a fair bit of time that's been elapsed between my husband, and who's also a patient in Better, felt the same way. There was, the time between visits kind of made it a little bit concerning for to continue the momentum. And of course, and this may sound a little bit irresponsible as a patient, but being monitored also helps patients, and certainly from my perspective, it helped to ensure that, you're going to follow through on your goals, and you're, making the changes that you need to make from a lifestyle perspective. So that's what, I would suggest that there would be a little bit more, and maybe it's unique to Labrador Grenfell Health. I don't know, because I hear Ashley did have, resources for Eastern Health, which is great, because I think, it's such an important program that we do need to give time and have more patients involved with it. That, in my perspective, that's what I, would see how it could be done better. And in terms of, the better being a valuable use of healthcare, I absolutely think that it is the way to go, because it's so focused on prevention. And I think as a patient, I'm feeling empowered, and I'm feeling more accountable with, participating in this program. And so I think I would represent most patients overall. So, and we know that the prevention piece is so important. And, if we can get more people into the prevention piece, then obviously they're going to, we will be able to have better results in preventing diseases, or at the very least in early detection So clients or patients would have better quality of life, and we'll have healthier communities, obviously. And I guess this is speaking more from as a previous healthcare professional. We know that our healthcare resources are limited, and our healthcare as it currently exists is probably going to be having to change because we can't afford it. So, like, you know, and we know that the intervention pieces are a lot more expensive than the prevention. So that's why I would highly recommend that we put a little bit more resources in our prevention piece to, at the end of some cycle, be able to get a better handle on our spending for, you know, the intervention pieces. And I think, you know, most importantly, I think it is a great way to engage people and make people feel that they're partners in the healthcare system and also in their own health, so that they can be a part of the solution to prevent diseases. And you know, I think that's really, really important. And pretty much that's all I've kind of given some thought to what I can say here today. So that's it. But I think it's a great experience, and I'm quite keen to carry on with it and see what happens. So that's it. Thank you.
Thanks, Glenda. I really appreciate you joining us today. Chris, did you have any final words you wanted to say before we move into the questions and answers?
I think in the interest of time, I'm not certain what I had, the extra things that I wanted to say would appeal to the full audience. So I think I'll probably turn it over to questions, because I understand there are usually a lot of questions. I did have a few thoughts on the role of researchers working together with policymakers on research projects and how that contributed to this project and us, well, really achieving what you've heard about today in terms of getting better from the research stage right to the health system implementation stage. So, but in the interest of time, I won't comment on that now, but I'm happy to take email questions or address that in the Q&A session if there's questions that pop up. So please, I'll turn it over to you, Jillian, to facilitate the questions. And if any questions do come up, then I'd be happy to comment on that if we have time.
Okay, thanks. So I'll ask our panelists to put their videos back on. And as just a reminder, if you have questions, put it in the Q&A box. If you have comments you'd like to share, make sure you're picking all panelists and attendees, and you can put the comments there in the chat section. Okay, so we're going to get started. And just also, in terms of the questions, Glenda has to leave half an hour earlier. So if there's any that are specific to where her input's being solicited, I will take those questions first. So I'm not quite going in order. So, okay, so first question is, this program seems to promote a lot of testing. How does this fit with the Choosing Wisely campaign that was supported by the Canadian College of Family Physicians? So I think, Chris, you had taken a crack at answering that, but do you want to expand a little bit on what the Choosing Wisely campaign is, and if you can go ahead and answer that easy first question that we have for you.
Yeah, sure. So Choosing Wisely, I would imagine that most of the audience is familiar with, but in case you're not, just very briefly, it's an organization that promotes rational use of healthcare resources. And so some of the things it specifically addresses are appropriate testing intervals and appropriate use of tests for correct indications, really as a way of saving the system money. There's evidence out there that shows 20–30% or so of testing that we do, or if interventions within the health system are actually not inappropriate. So Choosing Wisely arose out of that evidence to address that. They do make recommendations against some of the screening that is commonly delivered in primary care. And I just want to assure everyone that there was an extensive literature review process that went into developing the better recommendations and the better tools, and that all of the recommendations have a high level of evidence to support them. And so there's nothing that we do that disagrees with what Choosing Wisely suggests. And furthermore, it's not something that we've tested yet in any of the better studies. We've discussed it, but there may even be a reduction in some testing associated with better, because we are not recommending some of the tests that are currently being offered because of largely historical reasons, but no longer have sound evidence to really support them, such as PSA, prostate-specific antigen testing, and high-frequency diabetes screening, high-frequency cholesterol screening, which we often do those too often in primary care. So in some healthy patients, we probably don't need to do them as often as we do in other sick patients. So yeah, I think that's probably all I need to say on that. I don't know if Carolina or Donna had anything to add to that, but they certainly were heavily involved in that process, the evidence review process before, and so may have further thoughts.
Sure. So what I'd like to add is something that we didn't really talk too much about is patients do complete a survey as part of the program, but we also use that in conjunction with information from the chart. So part of the prevention practitioner's role is to determine what is out of date or off target. So it's truly if something, if someone is eligible for something, those are the things that we're talking about. And what the care map also allows the prevention practitioners to do is to determine if someone is at higher risk for a chronic disease, and perhaps the regular screening or the intervals may not apply to that patient. So they don't necessarily send the patient on for that particular screening, but they do then reconnect the patient with their primary care provider to have a conversation with them to make sure that those criteria for higher risk are actually present, and then to determine what the next steps will be.
Donna, did you want to add anything?
Just that sometimes people think choosing wisely is not choosing. And we do have evidence that patients at high risk for diabetes, we can actually prevent them from developing diabetes, or possibly prevent that. Certainly that's what the change, there's a program called Change that looks at targeting metabolic syndrome patients and improving their health through exercise and diet. So sometimes I think people go to the other extreme. What we're about is really about choosing wisely, about high-level evidence and what we should be doing both for detecting things early or prevention. And a lot of the focus is on behavioral lifestyle, that you know, it's not just about tests, it's about assessing diet and exercise and alcohol.
Okay, thank you. And Glenda, do you want to comment at all on your experience? I know you did speak quite a bit before, but did you feel like your tests were being pushed on you, or that it was things that may not have been? So how did you feel about that? And I won't let like Chris, Ashley, or Carolina comment on your judgment of the program. I think we may have just lost Glenda. Oops. Oh, hopefully she'll come back, or she may have had to go. So we'll see if she reconnects. But we do, one of the things I do want to emphasize in the PIHCI network is we do have patient and community partnership. It's a very big part of it. And they are sort of the check for just these exact types of questions in terms of preferences and ensuring that it's a good fit, not only between what is sound evidence, but also what is patient preference. Oh, Belinda, you're coming back on.
Oh,
I didn't offend you, did I?
No, I had a call coming in. I meant to push end, and I ended up leaving. My apologies.
Okay.
Actually, yeah, I would like to speak to that, because
Yeah,
I
go
really
ahead.
feel that the major focus, while it was important that we went through the 3 different chronic diseases, and I'm aware of my risk, which was really important, and what tests I needed done. And she did go through my chart to see. So I don't feel that there will be any repeat of tests that aren't necessary. And the focus certainly was more about my lifestyle, which, as I spoke to her in my presentation, I felt really good, because, you know, I have to take accountability for my own lifestyle and see what I need to do to prevent, you know, these chronic diseases. So I certainly didn't get the impression that this was going to be more tests, you know, it would be only absolutely needed tests, you know. So you know, I really need to clarify that, and I'm glad you gave me the opportunity.
Thank you, and I'm really glad you didn't hang up, because I put you on the spot. That would have been a bit awkward. Okay, so the next question is a little bit easier. It's actually from one of our patient partners on the PIHCI Pan-Canadian Council, And Olive is wondering is if this program exists in PEI, and maybe I'll expand on Olive's question. If it doesn't exist, what are the plans to try and expand this beyond just in Newfoundland? So I don't know, any of you
Sure.
can try that one.
So I can speak to that, definitely. So the program is currently not available in PEI. The Better Institute is pretty much working on a first come, first serve kind of basis. So we do have practices that are doing the program across the country, so not just Newfoundland. We have practices in Nova Scotia, New Brunswick, Ontario, Alberta, Yukon, and I think that covers most of it. So it's really just if practices are interested, we try our best to make connections with stakeholders in the provinces to make them aware of the Institute and the supports that we can provide. But it truly just depends on who comes to us and says, we'd like to do it. And we've been lucky in terms of the Eastern provinces with Newfoundland, Nova Scotia, and New Brunswick, where the interest really has come from the health authority level. And so that's where you see a larger spread in those particular provinces. But we have worked and do work with communities and individual settings to implement the program.
Okay, anything else there? So maybe I'll rephrase that question. Is there a way that the people on the community patient side of this can advocate? How would they, if they wanted their practice to take this up, what would they need to do?
So it truly just depends. They can definitely advocate and ask if it's a program that can be made available in their community and their settings, or even the patients could get in touch with us so that we can let them know what's happening in their communities. As I think all of the panelists and even Glenda pointed out, resource capacity is one of the things that sometimes prevents a practice from getting in touch with us to implement the program. Something that we try our best to do, as Ashley mentioned, is to adapt the program as much as possible to a setting. So perhaps it's not the classic better that they can do, but perhaps they can use the care map to inform the care that they are providing to patients. So there are small adaptations that can be made that can hopefully inform patient care. So they're more than welcome to get in touch with us, and we can let them know what we know is happening, or get in touch with their primary care settings. But it's very much an intake process for us right now, mainly because our funding with the Canadian Partnership Against Cancer is ending in March of next year. And so our capacity to take on new practices really is just dependent on who's coming to us, as opposed to us doing some outreach at this point.
Okay, thank you. Okay, so the next question is, so they're interested to know about the, EFT time. I'm not sure if that's supposed to be FTE, full-time equivalent, time that is spent for the interprofessional staff in the PP role. Is this usually their full responsibility, or do they do this as part of their role? So I think this is a technical question on how the program is working.
I can probably speak to that a little just from an Eastern perspective. I guess the roles that we have for Better, for our prevention practitioners, is a full-time role. So that is their sole job, is to do the prevention screening role with Better. I know of other places that have trained individuals to do Better, not full-time as well, but in Eastern, that's how we have implemented the program.
Maybe just a quick comment from me, if you don't mind, on that, related to that at least, is that most practices, in our experience, aren't big enough to really support a full-time role. So if that PP is based in a single practice, unless you have a huge group practice, of course, with many physicians. And the model of implementation that we've used at some sites is to have someone from outside, so a regional health authority employee who's not directly affiliated with the practice. And that actually has some challenges sometimes, because the the prevention practitioner doesn't know the other providers as well, and so we've had a few hiccups, I guess I'll call it, with that. So it's just, if in the ideal model where the prevention practitioner already has a role and a relationship with the providers, then it would not usually be a full-time role. So, you know, integrating with some other work that an LPN or RN or whichever provider you have would fit well, I believe, in most practices. But it can be, as Carolina said, and others, it can be adapted. So there's lots of ability to tweak with the model to make it work depending on the setting.
Okay, thanks. So next question. Okay, the person would like to know more about the steps after the assessment/prescription plan is complete. Is there regular follow-up? Is there someone who acts as a connector in getting resources and programs? And what do community linkages look like? Like you're talking about prevention, so sometimes there's resources needed. And I have a follow-up question to that, but I'll let you answer that person's question, and then there's something I wanted to add to that. Sure. I'm just going to lob it out there and let somebody go ahead.
Sure. So I can add kind of like the general kind of answer, and Ashley might have some other thoughts to add as well. So part of the prevention practitioner role is also to conduct an environmental scan of the programs and resources that are available in their community and their setting that they can refer patients onto, and what the criteria for referring, things like that are. So they should have a binder. They typically have a binder of programs and resources that they can adapt or refer to. What also helps as well, if it's a team practice, then they obviously have other team members that they can refer to. But in some of our Indigenous communities, it's very much a community approach. So they figure out within their implementation process, if someone is identified with X, what is going to be our next step. So it's a very collaborative process, particularly with the Indigenous communities, to figure out what their process is going to be, and which community resources beyond, I would say, even health programs. Sometimes it's a social worker or another program that they also refer the patient to, depending on what happens to come up during the visit and conversation. So it's a very much tailored set of resources that end up being identified for each community.
Any other thoughts to be added to that?
Just add to that. So that's that sums up nicely how, you know, the prevention practitioner, when they start within that role, is to connect with existing resources underneath the same clinic roof is very helpful. And that something I think that we haven't really talked about today too, that it's a really big positive of Better, is the ability to build teams very effectively. So, you know, just referring patients to different resources within that clinic setting is also very helpful for the success of the program. Of course, there's other resources, like Carolina mentioned, within that environmental scan that you refer patients to, maybe a smoking cessation or, you know, a walking group. There's lots of different things. And essentially, when our prevention practitioners in Eastern are hired, that's one of the components of our orientation, is to get accustomed with the area that they're working in as well, to ensure identification of those resources. I guess to just go back to your point about, you know, the follow-ups. So follow-ups are structured within Better based on the requirements for, it is at a 12-month checkpoint. What happens in rural Newfoundland is oftentimes that checkpoint may come a little sooner, depending if the patient, you know, may be in to see their physician. Sometimes they'll pop in and discuss some changes with the prevention practitioner. Sometimes they'll give them a call as well if they had further questions. So small town vibes definitely help with follow-ups there as well, but there is a structured follow-up and evaluation that's ongoing right from the time the patient completes the survey.
Okay, so I'm going to ask a little bit of, I'm going to elaborate that question and maybe make it a tiny bit more challenging. There's two things I wanted to focus on, if you could elaborate. One, you know, Chris and Donna and others have mentioned the review of evidence and taking the highest quality evidence, but you're talking about prevention and promotion of health. So first of all, nutrition evidence, like you can wait 5 minutes and get new evidence. So how do you keep for those types of things where the evidence is a, ever-changing landscape, how do you ensure that's up to date? And I got other questions related to that. One of the things is we know that like fresh fruits and vegetables have a major impact on health. There's the number of servings you get. That is one of the few things that have remained constant in nutrition evidence. What do you do about the people that don't have access? So when you're recommending interventions in health prevention and promotion, what happens when there is nothing to support them in doing something really critical for their health that we know follows high evidence? So an easy question for you, for everybody in the panel. And then Glenda might be able to speak to this in terms of what she was able to do versus what was recommended. But I'll open up to the rest of the panel first.
There are two tools that we found really helpful. One was the Dietitians of Canada Mediterranean Diet Toolkit. And Carolina may be able to speak a bit more to that, but that is, I think I understand it's being updated. And there is, substantial evidence around the items in that particular diet that impact health, such as omega oils, nuts, fish, that sort of thing. The other that I think in our better trial that we looked at was the DASH diet. So again, evidence around blood pressure control. But in the better right now, I believe it's the Mediterranean diet that the focus is on. And maybe Carolina, you could chat a bit on that.
Sure. So what I want to, I guess, emphasize in terms of the prevention practitioner role is that it is not an intervention role. So part of their role, what they're asked in the survey are validated tools, particularly with nutrition. They're just almost like quick and dirty screens of some of the areas where the patient might be making some choices that could be improved. So the role of the prevention practitioner is to look at their responses on that particular tool, which has been validated and has a certain score, and talk to them about their responses. And should the patient want to make changes in that area, they can definitely refer them on to a dietitian or another team member who has the skills to speak with them about that. And that is who does the intervention in terms of the nutrition. So we're not expecting the prevention practitioner to be the person who intervenes and is knowledgeable about all areas, but just to almost be the initial step in terms of getting the patient where they want to go after having that conversation. And in terms of the evidence, Donna and Chris can certainly speak to this as well. So we do, the evidence review includes currently international, national, and provincial guidelines. So our process is to review what is already available, look at harmonizing those recommendations, and truly looking at what is actionable in terms of recommendations. We make sure that what's in our care map is also what is being recommended in the provinces that are using the program. And if there should be any differences, then our prevention practitioners are always, our recommendation is that they always follow their provincial recommendations and what their usual practice is within their settings.
Okay, any further comments there?
I think just to add to that,
go ahead.
Just to add to that, I think that also goes back to the community involvement in Better as well, and really having a true understanding of what is available within the region, but also providing information as to where patients can get the best quality nutrition. So the other component of Better in small rural places is that it helps foster the development of other things like community gardens and all those sorts of things. If you come across patients that often ask those types of questions, it's just really about the knowledge of the prevention practitioner to be able to refer them on to the appropriate resource so that they have the best information to make the decisions for their health based on that information. So that's a good good follow-up there.
I would be interesting when you do your evaluation, how many times there's a disconnect between what they'd like to recommend and what people like to do and what they're able to do. Living in rural Canada in the depth of winter, organic vegetables are rarely available in the local store. So, and I don't care how big your garden is, there's only so much you can do with your diet come February in Canada if you're not living near a major city.
Yeah.
So, yeah, that'd be something interesting to see as it progresses. I mean, you have to start somewhere, right? But maybe that's a then becomes an advocacy issue for availability. Go ahead, Carolina.
Yeah, and I will say we do come across that in rural and remote communities, and particularly in northern communities. So the role of the prevention practitioner is to, they live in those areas as well and know the challenges too. So there are other recommendations that are made. You know, if it can't be fresh, because there's also a cost that's associated with fresh produce in those northern communities. If it can't be that, are frozen options available? Are canned options available? So they very much tailor the conversation to the reality that the patient is experiencing as well.
Thanks, and that's appreciated. I think a lot of us, especially with exposure to social media, it's like, well, that looks great. If I lived in California, that would work. I could get out on my paddleboard and eat my organic salad every day for lunch. So I think a lot of stuff is not adapted to Canadian context. So that's great to hear. And it ties into our next question, again, an easy one for our panelists. In prevention work, we always struggle to get support as we cannot prove cost effectiveness. Although I think COVID has helped us out a little bit on that angle. I think there's a little less convincing on the whole prevention and strengthening of the immune system now. But the question is, did you do any financial analysis that can be shared, or are you planning any, or is there something you'd like to do that would help strengthen this argument about investing in prevention?
In the original Better trial, there was some cost analysis. I don't know. I always have trouble because it's not really my area of research. But we did not find the practice level facilitation to be cost effective in any way. It wasn't significant. So that was not cost effective. The patient level we thought was, and we were able to put a dollar value on that. So the original Better trial does describe that. I know the Canadian Partnership Against Cancer had something called, I think it's called OncoSim, where they were doing modeling, and they did look at outcomes. Now, of course, we can't look at it at everything with Better, but you know, in terms of the prevention, it was found to be very cost effective. However, I'm very hesitant stating that because we didn't publish anything. You know, so what they did find is that with the reduction of cancers and things and early detection with the intervention based on the modeling that they had, that this approach was you know, worthwhile. But again, I'm always hesitant because we haven't published this, and you know, and I really don't understand economic analysis. So that's all I can say. Maybe Carolina might have some further comments.
Yeah, I think that's a great summary, Donna. As Donna mentioned, we did a cost effectiveness analysis as part of the initial Better trial. We actually looked at patient outcomes. So that's the reason that it's a little bit difficult to explain. We did find that it was cost effective, but it was very much based on our composite outcome, which is based on whether a patient was eligible at the beginning of the study for any of the specific chronic disease screening or actions, and whether they actually completed them at follow-up, which for the trial was around 7 months later. And the OncoSim modeling was very much at prevention of cancer cases. And it's because of it's the Canadian Partnership Against Cancer. It was solely cancer outcomes that they were able to model. And as she said, there's a lot of caveats with modeling, but it was found to be cost effective.
Yeah, I think that's one thing that's a huge challenge in primary care is trying to measure the impact of what didn't happen instead of, like, it's easy to count, right? It's easy to count strokes and heart attacks and everything else, but it is more difficult to, you know, say, okay, we prevented 6 strokes when the strokes didn't happen. But I think that's where the argument for health-related quality of life measures and patient-reported experience and patient-reported outcome measures becomes really important. So where we stop measuring things from a very clinical perspective, where it's like lab tests and disease counts and diagnosis and symptoms, and we measure it from the perspective of impact on patients' lives. Because then you can actually, I know this isn't Donna's area of expertise, but with some of the implementation work I do, we actually can put a dollar value on health reported quality of life. So what you as a patient feel about what you can do in your daily activities, how you feel, including your mental health, which is often something massively overlooked in health services research in terms of an outcome. So all of those things can be measured, and it's just a matter of advocating that those are valid measures of programs such as this, because yeah, you can't measure something that didn't happen. Well, you can, but it's very, very complicated and people really aren't very confident in the results. So there's other ways. So thank you. But it is, yeah, I think prevention is hard to do, and it's hard to show impact because it's also long term. Like you don't see it immediately, you see it down the road and hopefully sustained. But it is something we have to focus on. COVID has given us a lot of impetus to do that and some credibility in that area, since they've now figured out that doing the reactive thing doesn't work out so well. We could have told them that in primary care, but whatever.
I just wanted to mention something briefly,
Chris.
Because it may not have been clear from what Donna said there. So the original cost effectiveness analyses from the BETTER trial are published together with the outcomes paper for the BETTER trial. So you can find that. The stuff that's not published is the modeling work. And so the outcome for the BETTER trial was the cost per additional prevention item met. And probably don't want to go into details of that now, but we can answer questions by email. The modeling outcome was more around prevention of cancers, as you heard. So, and my pet peeve, not pet peeve, but I think the significant omission that really, I mean, it was a valid omission, don't get me wrong, but I think there's a potential for BETTER, when it's fully implemented and well implemented in a clinic, to actually result in physician time savings. So it's time that I no longer have to spend counseling patients on various prevention issues, filling out requisitions, sending in orders, interpreting results, those sorts of things. That's all things that can be transferred over to a prevention practitioner provider. So there should be some cost savings there, which we didn't consider, or Donna and the team at the time, I wasn't involved at the time, it wasn't considered in the original cost effectiveness modeling. So I'm hopeful actually that it will come out looking quite good if and when we ever get a chance to do a more in-depth modeling work.
Okay, and I will ask somebody on the team to put in some contact information in the chat. So does that email you keep referring to, people know where to contact for BETTER. Okay.
Sorry to interrupt, but I have to leave at this point.
Okay, Belinda, thank you so much for being with us, and good luck with the project moving forward. We appreciate the time you took to be with us.
Thanks, Belinda.
Thank you. Yeah, bye-bye.
So the next question, which was bound to come up, it's certainly an issue, is due to COVID, is there any of this that could be done virtually, and has anyone adapted? I know I've pretty much had to adapt my entire research program for COVID, and Zoom plays a large role in that. So I know that there's a lot of virtual visits going on, and it works really well for some things and really doesn't for other things. And one thing, when you consider answering that question, it would really be great if you could think about not only like just the technical aspects of the program that can be done virtually, but whether, because a big part of a lot of what you're talking about is relationships, and a good relationship between your prevention person and the community member or patient. So can you speak to, can everybody speak a little bit to how this is being adapted, but also how you think it might impact the development of trusted relationships?
So I can give you a bit of an overview. Sorry, Donna, did you want to?
Yeah, no, you've got it. We've had to do it. We didn't.
Yes. So we have had some adaptations done in terms of the virtual world, both from a research perspective and implementation perspective. So where the challenge comes is in resource capacity. So as COVID, that landscape changes, some of the capacity to continue on with Better, or even for a practice who was planning to launch Better when COVID happened, some things had to be pushed away. So for those practices or settings that actually had continued capacity, they have moved to virtual, perhaps with less time allocated to Better than they originally had planned. But for those practices that went on to virtual, most of them actually were almost in the follow-up phase. So it wasn't necessarily a lot of initial conversations that they were having with patients. So relationship was already existing. For those that were brand new, and actually we have had a few that were brand new and started launching the program with virtual, it almost depended on who was taking on the role of prevention practitioner. If there was someone who was already embedded in the practice and who the patients already knew either in another capacity, the relationship building sometimes wasn't as difficult. But for someone who, even if they were embedded in the practice but was not known to the patient, having a virtual visit can be challenging. And depending on their capacity, sometimes a virtual visit is not like a Zoom, it's over the phone. So even then, when you don't have a face to see, it can be a bit challenging as well to create that connection. So a lot of our conversations have been on language and how to build that rapport with a patient if you can. The other challenge has been as well, where in some of our provinces for a while there, they were very much recommending that patients not be sent for any screening that was not high priority. And so since we look at primary prevention and screening, some of the adaptations have also been to focus on the lifestyles instead of focusing on lab work or a mammogram or things like that. So there have been a lot of different adaptations that sites have done, given their capacity to be able to continue or start with the program.
Donna, do you want to add to that? Donna? Oh, you're on mute still.
Yeah, no, I think that covers it. We've had to adapt, certainly with our Better Wise research project. Our patients are following up their 12-month visit and it's all being done virtually. Now, certainly they've had a first contact in person, you know, and they have established a relationship prior to that visit, you know, so would that be different? Maybe, you know, so maybe it is good to have a first visit in person and then follow-ups can be done virtually. Certainly the virtually is working.
The only part I'll add to that is just to say that for Better Wise, our current phase of the research program, our control group is a waitlist control group, and they have just been started to be seen or will soon start to be seen either over the last few months or upcoming in the next few months. And so, of course, they will be virtual visits exclusively. We're not seeing anyone in person, I don't think, at least. And so it's not ideal, of course, but we're forced into seeing patients virtually. And we actually had no plan to measure longer term outcomes with the control group, which now is unfortunate. Maybe it would be very interesting, of course, because we could have some sense of what the outcomes look like with virtual visits versus in person as sort of it's an unplanned analysis. So I don't know, maybe that's the next grant to apply to a follow-up to get some resources to do those to do those assessments.
So I have a little follow-up question on that, because one of the things we're noting, and it was interesting that Carolina noted that some people call because they don't have. So one thing we're finding, the hope was that virtual visits would actually improve access to care and reduce inequitable access to care. But because people, especially in remote or rural areas, may have relied, or in small towns, or who don't have home Wi-Fi because it's not free in Canada, and actually we pay more for our cell phones than any other country in the world. So might have relied on a local library that's now shut down, or they may not have good Wi-Fi, or they may not have the access. And actually it looks like this is now creating even further divide in terms of who has access to care and who has access to what type of care. So are you monitoring this at all in your project, or taking any steps to mitigate the fact that you're obviously going to get people who are better off in a better socioeconomic situation, who would have, you know, the camera with the mic and the earphones and everything else? Anyone want to comment on that?
So from the implementation side, the capacity to continue to with virtual, whatever that might look like, whether it's on a computer or via phone, is completely dependent on the capacity of the site, of the primary care site. And so they very much follow their clinic protocols in terms of what they would offer in terms of care. So we're not receiving feedback in terms of the success of that so far. We haven't heard anything in terms of course, there are challenges. We already know that there's internet challenges. And even sometimes a call in Newfoundland can be long distance, even if you're not that far away. So we definitely recognize that. We've seen a lot more of that, I would say, in our research study. So I'm speaking specifically about Better Wise. What helps a little bit in terms of our outcome is that in each site, each geographical area, we have both intervention patients and control. So hopefully with the randomization, it would help mitigate some differences between both of those groups. But perhaps some of the other team members have some thoughts that they would like to share too.
No.
Well, I guess speaking from, actually implemented better in very rural places, and up until COVID, we were doing everything face-to-face, with the exception of, calling patients for their appointments. We've really had to get creative and innovative in respect to virtual care. We currently, when COVID hit us in Eastern anyways, we, like Carolina mentioned, we halted better operations for a period because the needs were in acute care, and of course, anticipating a large volume of acute care patients due to COVID. So our program really was flipped upside down. However, now looking towards, new innovations to be able to deliver the service, we do have electronic medical records in which we can deliver virtual visits. So that's something we're exploring. But we do also now, as part of our management group, have a business partner with Innovations for Technology. So that's something that we're exploring to be able to offer service to patients within this area virtually. So I guess more in the future as opposed to what we did previously, and just trying to overcome those obstacles that you speak about, because yes, long distance to call St. Mary's from St. John's, it sure is. So lots of things to consider, absolutely.
Yeah, and those plans that include all calls across Canada are not insignificant if you can get cell phone service. I remember my house I had in New Brunswick, I had to go to the upstairs back bedroom window and practically hang out of it to get 2 bars of service. So again, another thing in Canada that a lot of people might take for granted elsewhere that we do very poorly. So another advocacy point for us. Getting better cell and Wi-Fi access across the country at reasonable prices. But yeah, we look forward to hearing how you continue to adapt to that. So the next question is actually something I was thinking about as well, so I'm quite happy to share this with you. And the person has asked if you can describe the mental health assessment of the Better program. After all, overhealth is inclusive of psychological well-being beyond the physical health component. And I'm interested in this particularly as mental health has always sort of been the sort of ignored epidemic in North America. And now with social isolation and everything else that's coming with the sheltering at home and social distancing with COVID, I think we're going to see a huge increase in mental health. And I think prevention there is incredibly important. So what have you done to date dealing with this in terms of the standard program? And are there any thoughts about how you might be adapting this or upping that part of the program considering our current context?
Yeah, so with our original Better trial, we had 2 strata, and I didn't mention that, but there were strata. There was one strata that had moderate mental illness and a general health strata. So in the original Better trial, we did look at, how this works in patients with moderate mental illness, because we knew they were disadvantaged, and there had been really research done to look at chronic disease prevention and screening in patients with moderate mental illness. What we did find is that they also had substantial improvement in chronic disease prevention and screening, similar to the general health group. We went a bit further because in the Better trial, we had used, some anxiety and depression tools. And there is another publication, and I can't recall all the details of that publication, but we were, curious, about, learning a bit more about that specific group. What we did find very briefly, and again, I need to look at the details of the paper for the specifics, is that patients with, anxiety and mental illness come in with fewer of their actions achieved. So on average, we find that people often have around 9 actions that they're eligible to receive. With moderate mental illness, they have more. And though they improve, so they, through the intervention, they do not come up to the same level as as the patients without mental illness. Maybe they do over time, but in the Better trial data, they didn't. With the further iterations of Better, we did review the guidelines about what should we be doing. And we found with the recommendations are around screening for depression using a 2-item screener, the PIHCI. So it's a 2-item screener, and it's included in the survey. And patients, that are positive, that, that is something the prevention practitioner would identify and then refer on to resources and programs that they've identified within their practices. And Carolina might have a bit more to, add what is happening right now in terms of the Better Institute with that.
Mm-hmm. So definitely. So as Donna mentioned, the questions that we ask typically as part of Better is whatever has been recommended in terms of screening at a population level. So what's currently included in terms of mental health is to screen for depression. Having said that, as the evidence changes, we will incorporate other validated tools specifically in the survey. But during the conversation with a prevention practitioner, the prevention practitioners very much broach the subject, not in terms of diagnosing or identifying a particular condition, but as a mode of conversation. So they'll say something like, I noticed that you answered that you were feeling down most of your days. Can you tell me a little bit about that? And so their role really is, again, to be that connecting piece to another resource that can intervene or have that more in-depth conversation with a patient if the resources are available in the community. And we already know that in smaller and remote communities, sometimes having that mental health piece is difficult because the resources just may not be available locally. So we do have a list as part of Better of any programs that are available within a province or nationally that the PPs could refer a patient to help support those conversations that they may not be able to have in their communities, but that is their role to link the patient up with a resource that would be helpful to them.
Yeah, I think that's one of the challenges, of course, is that a lot of non-pharmaceutical interventions for mental health are not covered by the healthcare system, and it's out of pocket. So once again, those that need it most are the least likely to receive it. And I think that's always a challenge of prevention. You know, a lot of times it's not that people don't want to do the preventive behaviors, it's just simply not within their grasp, whether it's financially, time, or resource wise. So I think that would need to be a special focus for any program. Of course, we want everybody to be healthy, but when we're just making healthy people healthier, and I don't think that's what the Better program's doing, but it's always a risk with programs that it's the worried well, and they're just they're doing better. So it'll be interesting to see as you move forward the results around that, like are we truly reaching our most vulnerable populations who probably need this the most. So that's one subject near and dear to my heart.
Yeah. So the nice thing about this program is we saw improvement in those with moderate mental illness. So we know it impacts that group. And I think that's really key, is that we need these kind of programs that work, and we need to look at these groups.
There's just one other comment that Donna didn't have much time to mention. I think she touched on it briefly, and that's another phase actually that's currently ongoing of the research program in Durham, Better Health Durham it's called, where the intervention's been adapted to be delivered more in a public health setting by public health nurses with some more disadvantaged, marginalized patients. And we don't have any results on that yet, but we'll soon see, I think very soon, right?
Results are being written up.
Ah, good.
So keep your eyes open. Yeah. It's, I think, good stuff.
I think just to add to that from our experience, particularly with the St. Mary's site, I know I refer to that one a lot, but it was our very first site, and it's our most robust. But to go back again to, Caroline is speaking about that prevention practitioner identifying those issues that come forward in that patient interview. One program that we do offer out of St. Mary's, which is a very rural site, as I've talked about, is a walk-in mental health service. So again, having that team under one roof where you can simply refer a patient while they're actually, having the visit with the prevention practitioner has been very helpful for us as well. And we do have patients who get referred to, simply go down and speak to the mental health counselor. And it is a counseling one-on-one session. It's called Doorways. And like I said, it's a walk-in service, which has been very helpful at that site. So it's certainly something, again, in that prevention practitioner's toolkit to understand what's available to offer those patients.
Great. So we have one final question, and then I'm going to ask for just a 1-minute summary from each of the panelists on their final thoughts, and I've got some concluding remarks. Just to let everybody know who's still in attendance, Jamie has posted in the chat the site where the video recordings of these sessions are, as well as to register for the 2 future sessions. Okay, so the final question is, any thoughts about integrating the program or principles into medical education programs? So I know that medical education prevention gets like, I think, an hour of time, but so thoughts on this? I know maybe Chris and Donna might be a little more involved in the medical education training program world. Ideas there.
Yeah, so undergraduate curriculum, that's a whole different topic. Yeah, so I mean, you are talking at a different level. I have been invited to talk to medical students in that, and I do bring, like, this does inform a lot of my presentations, but in terms of having it right in the curriculum, those discussions have not been had. you know, so a lot of the curriculum is developed and controlled by primary care doesn't have a very strong voice at some of these tables. So maybe Chris can talk to that a bit too.
Yeah, I guess I have a maybe a little bit more of a provocative response in that I don't think it belongs there in medical education. Actually, I think as physicians, we're more trained, as really we've alluded to throughout a lot of this discussion, we're more trained for dealing with diagnosis of new presenting complaints and to some degree in management of chronic disease. But I think the better program, the better randomized trial, and some of the other evidence that's come out has shown that others are better at dealing with this than we are as physicians. And so I think it belongs in primary care nursing curricula, maybe in LPN curricula. We've shown that LPNs can do this quite well in Newfoundland. There's been a number of LPNs here that are doing it. And I think it's something we have to consider. Nobody likes to talk about it, but they're more cost-effective providers than physicians are for doing this stuff. So, and we all know about the issues with health system efficiency these days. And so transferring this to other providers, I think, is a better solution. What they do need to teach us better about, the physicians I'm talking about, are how to work better together. So how can we work best in teams? And that's the other part about better that I love, is that what I use is, and what I think helped to get some buy-in from it at the provincial level, is that this is part of a multidisciplinary team in a package. It tells you how your team should be functioning together. It tells you what the nurse or LPN can do, when they need to hand it off to the physician for the physician's involvement, and why, and that sort of thing. So this is what we need more of, this type of approach. So that's a big part of what I wanted to, or why I've been involved with Better, because it really fits with my vision of a team-based system of primary care.
Yeah,
I think that's actually, oh, sorry, go ahead, Carolina, go ahead.
Oh, sure. And if I could just add to that, I think I would agree with Chris as well. As you can see from some of our stats, most of our trainees come from nursing background, but just informally, we have actually had students join our training sessions because they're interested in learning more about primary care and prevention. So, and between now and the end of our funding, we'll be doing virtual training sessions. Of course, in person is just probably unlikely. And of course, they're welcome to participate in those training sessions as well. So we have had trainees join us and who are planning to go back to their communities and bring Better with them.
And I think that's actually a really nice, we're almost out of time. That's a really nice wrap up and concluding messages. Or any final words from our panelists before I do my concluding remarks? All right, so I'm, Donna, do you want to say something, or are you just not getting off mute fast enough? Because I'll keep going. Okay, I do want to thank all of our panelists for being here today. I also would like to thank all of our networks are funded by the Canadian Institute for Health, the Canadian Institutes of Health Research. I was going to add in services there. That's a separate institute within the Canadian Institutes of Health Research. But they also all have, including the Network Coordinating Office, they all have matching funding. So they're all supported by partners, different provincial and territorial funding partners, and without all of that support, this would not be possible. So we'd like to thank the funders. As Chris mentioned, primary care research is complicated and difficult, and we need a lot of players there. And the networks have done a superb job on pulling together people, not only within their own network from all different roles, as you saw from our panelists today, but also across Canada. And into the territories and with different community groups, which is, we're sort of arguing this is the way things need to be done. So we will be sending our webinar attendees a survey. Please complete it, including looking for topics you might want to hear about in the fall as we continue this into the fall. And our next session is going to be on big data in primary care, and that will be held August 18th, and the host is Alberta, the Alberta PIHCI network. and get to hear about what is the data available to answer these complicated questions and some of the work they've been doing to move that forward. So Donna will be coming back to your home province. So moving across the country from the East Coast till further west. So I hope to see you there. Somebody very kindly put in Canadian Institutes of Health Research in the question so I can quit garbling things. One too many Zoom meetings for me these days. I hope to see you at the next session. I wanted to thank everybody who, especially our panelists and the attendees who took 2 hours out of their day today to learn about this great initiative. And I hope in a year we're back to hear more exciting results and follow up on all those great questions. Okay, thank you very much. We will leave the chat up for 1 minute and we will be ending exactly on time. So thank you and goodbye for everybody in Newfoundland and those who attended across the country.
Thanks very much, Jillian and Jamie, and to the rest of the PIHCI team. Really appreciate this opportunity.
Yes, thank you to Jamie and Stephanie who helped organize this. I keep forgetting my team that actually makes all of this possible, and that certainly is not me. So thanks, Chris, for pointing that out. Goodbye, everybody. Have a great afternoon.
Take care, folks. Thank you.
Bye. Thank you.